Please start.
Good evening, everyone. Welcome to the Wednesday evening session. I'm talking about role of radiology in acute and chronic chest infections. I'm going to split this talk into two. Probably next week also I'll talk about the chest infections. So here introduction is, as you all know, the diagnosis and characterization of any infectious or inflammatory processes is most often performed with conventional radiology. That will be the first line of investigation modality, and then followed. They are usually supported by the biochemical tests. But however, the radiological techniques, as you know, they only show the anatomical changes. We cannot really get the function out of it. Nevertheless, and you also have to notice that the conventional imaging, the changes that appear are slightly delayed when it comes to this is a general introduction. So whereas in chest, I think it's fairly in a fairly early stage we can pick up the findings on conventional imaging, say in example for pneumonia and things like that. But however, if it is an interstitial disease or a focal disease which is obscured by the cardiac borders, so it may not be able to depict the findings on the chest radiograph. So hence this delays to delay in diagnosis many a times. So hence we have to adopt new technology, radiological technology such as CT scan and MR that's also being used, but less in in chest imaging. And not to forget about the radionuclide imaging. The role of it is not great for the regular chest imaging, but only in extraordinary situations like you want to diagnose pyrexia of unknown origin. You want to locate the focus of infection. Probably that's where it will help. The PET CT or PET MRI also can be used. So moving on to the chest infections proper. So these are the most commonly encountered outpatient and inpatient clinical care. Right. That's the patient comes with cough, cough, hemoptysis, chest pain, and things like that. So, and then imaging studies, as you all know, it's very critical in diagnosis and management of pulmonary infections. So when you have to remember when the imaging manifestations of a known disease entity form a consistent pattern or a characteristic appearance, those manifestations may be regarded as imaging sign of the disease. We'll see the examples of this, what I am talking about. Okay, so moving on to, and also imaging signs, many times they're non-specific. You'll see an opacity in the lung, which you don't know whether it is an infection or an inflammatory process or a neoplastic process or a non-infectious process. Rather, so it's so as a result, what we have to do is we have to take into consideration the clinical history, clinical data, and the biochemical and the hematological investigations such as white cell count and all these immune status. All should be correlated along with the imaging to come to a conclusion of what exactly is going on with the patient. So now I'll talk about the disease patterns in pulmonary infections. The first and the foremost is the consolidation in the air bronchogram. So this is the first one you will be taught when you enter your medical school, rather radiology program, when you enter this radiology program. So this is nothing but an alveolar filling process that replaces the air within the alveoli, affecting the air spaces and increasing the pulmonary attenuation. As a result, the alveoli are filled with some sort of fluid or a mucus or an infiltrate or an exudate, which will obscure the which will increase the pulmonary attenuation. That means they look bright compared to the aerated lung, and thereby obscuring the margins of the adjacent airways and vessels on radiographs and CT scans. This is a common sign. This can be seen in any pneumonia or atelectatic lung also can be seen. So right, this is how it looks. Classically, you can see this right upper lobe pneumonia with air bronchograms, beautifully demonstrated on the chest radiograph. Another patient on the right side with CT scan, you can see this air bronchograms, very well demonstrated in a consolidated lung, in lung consolidation. Mind you, for the air bronchogram to be visible on the chest radiograph or CT, the bronchi should be patent. The proximal bronchi should be patent. Otherwise, this sign would not be there. You will not see this sign. So hence, is one of the, as you know, is one of the more common manifestations of pulmonary infection, and its appearance is variable depending on the causative organisms. I'll show you some of the how the causative organisms. Some of the organisms may have a typical appearance. I'll show in the examples to follow, or in the next talk. And the next sign is the silhouette sign. Silhouette sign is, as you all know, it's everyone talks about the silhouette sign, and this describes loss of normal lung soft tissue interface caused by any pathological mechanism that replaces air or displaces air within the lung parenchyma. So it is important to consider a diagnosis of bacterial pneumonia in a patient who comes with fever, cough, and a silhouette sign is present. So this is how a silhouette sign is present. Silhouette sign. On the right is a normal chest radiograph. You can see the left heart border is beautifully demonstrated, which has a sharp margin. Whereas on the left side, you can see, though you can see this is an over-penetrated view. In spite of that, I'm not able to see the left heart border. That's because of the pathology. That's a pneumonia in the lingula that is causing that appearance. So you need to make use of these appearances, and this can be seen in, if the pneumonia is in the lower lung, it obscures the hemidiaphragm. So that is also, it's a sort of silhouette sign that will help in diagnosis of pneumonia if patient has fever and cough. So next is the tree in bud sign. As you would have heard, this is a very commonly used terminology. Okay, it's a CT terminology. Basically, you need to understand that it's a CT terminology. We can't see this on a X-ray or a radiograph, chest radiograph. So these are nothing but the small airways or the terminal bronchioles, which are otherwise normally invisible on CT images because of their size. They are less than 2 mm in size, and the walls are less than 0.1 millimeters. So this becomes why we are able to see this is because these bronchi are filled with, as I said, mucus, pus, fluid, cells infiltrate, forming impactions. As a result, we start seeing these terminal bronchioles. Hence, this tree in bud appearance name is given. So these basically resemble branching nodular V or Y-shaped opacities that are referred to as tree in bud sign. Here is an example. This is how, and initially, this is an example here. You can see the bottom image, which demonstrates that tree in bud appearance. You can see this is a terminal bronchiole with branching V and Y opacity. This is a V opacity, and a couple of them are Y. So this is how it looks. This is nothing but the bronchial tree. The entire bronchial tree you need to take into consideration, and the distal part of it looks like a bud. Hence, it is given that name tree in bud. And initially, it was thought to be specific of mycobacterial infections, but however, it has been seen with many other conditions. Hence, it's no more specific for tubercular infections. It can be caused by any of the other organisms like bacteria, fungi, and parasites, other viruses as well. And mind you, this appearance is very characteristic of an infectious bronchiolitis. Okay, whenever you see this, you can be very sure that but there is an underlying infection. In fact, there are a lot of mimics in the chest radiograph or the CT chest. But if you ever see this tree in bud, you can be sure that this is an infection. We have to determine what infection it is. And sometimes this aspiration also gives rise to the tree in bud opacities in the lower lung zones. Okay, next is the bulging fissure sign. Is nothing but there are fissures in the lungs. Whenever there is consolidation, it can, if it is expansive, and it may cause fissural bulging. And this bulging, this is because of the copious amounts of inflammatory exudate that accumulates in the alveoli and alveoli or parenchyma, which gives rise to this appearance. This is how it will classically look like. You can see this. Usually, the fissures are either horizontal or it may it have a concave border. In this case, you can see it is kind of pushing down. It has this typical convex border. bulging physical of Klebsiella pneumoniae, but it is not so, and it is being seen with many pneumonias, especially the pneumococcal pneumonias. And the next one, inhomogeneous and cavitation, an important sign. In patients with pneumonia, if you are dealing with a patient with pneumonia, on CT, if you see this, I'll show you the example how it looks. This is how it looks. You can see there's a little bit of effusion, there's consolidation, there are air loculi within this lung parenchyma, which shows that heterogeneous enhancement. Okay, this is not the normal lung. Normal lung would show the vessels, but this, right? Normal lung would show the vessels, but that's not the case here. You can see heterogeneous enhancement all over here. Here is another example which shows that heterogeneous enhancement of lung parenchyma with air loculi. There's a effusion, there's a pneumonia, air bronchogram, all are depicted here. Okay, so this, if you see anytime you see this kind of pattern, inhomogeneous enhancement and cavitation, this suggests necrotizing infection basically. This finding is often seen before a frank abscess is formed. This will necrotize and it will form an abscess, and this will be coughed out through the bronchi and the trachea, right? So this, whenever you see this, this means a prolonged hospital course. Patient is going to be there in the hospital for a longer time. So what happens in this case is the bacteria causes this pulmonary necrosis, and this will result in this kind of appearance. Okay, cavitation, inhomogeneous enhancement, and leading on to cavitation. So this may be a result of suppurative or caseous necrosis, as I said, or lung infarction can also give rise to this. Importantly, cavitation does not always indicate a lung infection or abscess. You have to keep in mind even the neoplasms can give rise to the cavitation. So you need to be cautious in interpreting things. You have to keep in mind the history, the presentation history, and you have to correlate everything. The biochemical investigations and the blood counts, everything keep in count, and that will lead, you can give a reasonably decent diagnosis.
Hello, hi. Sorry for the interruption, the technical glitch. I moved to a different system. Yeah, we were talking about the other disease pattern, which is inhomogeneous enhancement sign and cavitation. This is when in a patient with pneumonia, the CT detection of inhomogeneous enhancement and cavitation suggests the presence of necrotizing infection. This is what I was talking about. I can see in presence of a pneumonia, if you see heterogeneous area in the region of consolidated lung with air pockets. In this patient, you can see the pleural effusion as well. There's another example which shows that heterogeneous enhancement, and if you ever see this with air loculi in it, this is show of necrotizing pneumonia. So this often seen before the formation of abscess formation, and this suggests that the patient is going to stay in the hospital for a longer time. So always this can be pulmonary necrosis, can be it can be due to the result of suppurative or caseous necrosis, or lung infection can also give rise to this. Importantly, cavitation does not always indicate lung infection. You need to remember this. A lot of other conditions can give rise to this cavitation, like malignancy, radiation therapy, or lung infarctions. Hence, you need to carefully interpret. You have to take into consideration the clinical findings, clinical, biochemical, and hematological investigation findings. So the next is the air fluid level sign. So in a patient with a pneumonia, if you ever see a air fluid level on chest radiograph or CT images, this suggests a lung abscess, or this could be related to this, or an empyema with a bronchopleural fistula. This is a classical example demonstrating that air fluid. This is a erect radiograph of the chest showing that fluid level. Same one on the lateral view suggests demonstrating that fluid level, and the CT demonstrating same with with surrounding consolidation. So this This is a typical, this is seen in, as I said, in lung abscess or empyema bronchopleural fistula. But however, lung abscess can be treated with antibiotics and then IV antibiotics and follow up. Whereas empyema, we need to do a chest drainage for draining that empyema. Okay, moving, and the common causative organs are the Staph aureus and Klebsiella pneumoniae. And as you all know, this is always, lung abscess is always associated with increased mortality and morbidity, and the imaging certainly helps in diagnosing it and following these patients. So next one is a Split-Pleura Sign. Normally we do not see this visceral and parietal pleura on CT images. We cannot really distinguish unless there is an inflammation or an infection in this pleural cavity where these the visceral and parietal pleura enhance with a fluid in between these two layers, and that's when we can call this as a Split-Pleura sign, and this is a classical sign of empyema. We can, if you ever see this kind of sign, this is a non-contrast CT with a normal pleural, not normal, with a pleural effusion which doesn't show any pleural walls. Whereas in this patient, you can see on the right side, you can see this pleura are split, and this fluid is accumulated between them. More often than not, this is loculated, and this definitely needs drainage through a chest tube. Otherwise, this is not going to get drained, right? So obviously, when you see this finding and the associated findings of fever, cough, and chest pain, and the CT shows split pleura, then you can be very sure that we are dealing with empyema. And mind you, this finding can also be caused by malignant effusions or hemithorax sometimes. But in presence of fever, probably you can say that's related to infection. So next sign is the halo sign. This is a CT finding again. It's you cannot appreciate this on a chest radiograph, right? So this is how it looks. An example of how a halo sign looks. This you can see a focal consolidation, mass-like consolidation. Some air bronchograms. You can see this at the periphery. This halo. Whenever you see this halo sign, you're most probably dealing with a some sort of invasive Aspergillus infection, and the ground glass opacity is because of the hemorrhage surrounding the infarcted or infected lung caused by vascular invasion of these fungus, right? So the halo sign is typically seen in the early, mind you, it's seen in the early part of the early course of the infection. So it is important that the patients need to be imaged. Here there was a study done in a group of 25 patients, in patients with invasive Aspergillus infection. The halo sign was seen in 24 patients on day 0 and was detected in 19% of patients by day 14. So hence the earlier the better. Earlier the better you can diagnose this fungal infection, and appropriate antibiotic therapy can be initiated. So the differential considerations for halo sign are mucormycosis, candida, pseudomonas can also, all these infections, the viral and some of the bacterial infections can also give rise to this. Not just that, even the non-infectious conditions like Wegener's and Kaposi sarcoma or hemorrhagic mets can give rise to this appearance. So you need to, as I said, you need to take into consideration all the clinical, biochemical and other parameters to arrive at this diagnosis of invasive aspergillosis if you ever see this halo sign. So next is the air crescent sign of angioinvasive aspergillus infection. The air crescent sign is a CT finding again. Probably we will not be able to appreciate on a radiograph. On CT we can diagnose this without much difficulty. This sign is seen in two types of infection: Aspergillus infection, angioinvasive, and mycetoma. Here you can appreciate this on radiograph, on CT images with lung windows. You can see surrounding when there's a consolidation here in the lung, with you can see air crescent all around with a central infarcted or necrotic tissue, necrotic retracted tissue, which is indicated by the star sign. So this is very classical of angioinvasive aspergillus infection again. Right. Um, this is typically seen after 2 weeks, 2 weeks of the after the infection, and coincides with the return of neutrophil function. So this so you need to again here the clinical history becomes important. How long the patient has been having fever and symptoms of chest infection. So by this we can arrive at the diagnosis. And the next sign is the air crescent or monod sign. This is slightly different from this sign, which is called air crescent. This is called monod sign of mystoma or air crescent. It is also called as by the same name, but it has a different appearance. I'll show you. This is how it looks. You can see this. There's a cavity with a with intracavitary soft tissue density. This is more commonly happens with following tubercular infection or a sarcoidosis, right? So as a monod sign, it's seen in immunocompetent host. Basically, you need to remember this: immunocompetent host, and pre-existing cystic or cavitary lung disease is mandatory for this. As I said, it's we call this fungal ball or mystoma, right? And this, once it was thought to be specific of Aspergillus infection, however, the same appearance can be seen with many other conditions like neoplasm, intracavitary clot, and Wegener's granulomatosis. Next sign is the finger in glove sign. This is nothing but the bronchi are filled with the tubular branching tubular opacity that are filled with that usually emanate from the hila, start from the hila, and resemble a gloved fingers because of the either mucus or the fluid impacted in those bronchi. So I'll just show you the examples of that. You can see on the radiograph, these are the finger in glove appearance, classical how it looks on CT, and this is once thought to be typical of bronchopulmonary aspergillosis seen in patients with asthma or cystic fibrosis. But however, a lot of other conditions can mimic this glove and finger appearance, especially the endobronchial tumor, which will obstruct the bronchus, then give rise to the installation of the mucus, and give rise to this appearance. So hence, we need to correlate with and even the bronchial atresia or post-inflammatory bronchiectasis can also give rise to this appearance. We need bronchoscopy to exclude endobronchial tumor as a cause of finger and glove appearance or a sign. So the other one, next sign is the reverse halo sign or a bird's nest sign. So these are usually seen together. We already saw this halo sign where we are seeing a mnemonic patch or a nodule kind of thing with surrounding halo sign. This is the reverse one. What happens here is you can see here there's a consolidation all around, and there is a central or an eccentric halo. This is called reverse halo sign, and these are crisscrossed with multiple septations. Septations or interlobular septal thickening. This is called reverse halo sign, and this is most commonly caused by this invasive fungal infection. Like again, this angioinvasive can give rise to this infection. Or a mucormycosis can also have this kind of appearance. This is more common in neutropenic patients, the sign of this reverse halo and bird nest signs, and it can be associated with multiple pulmonary nodules as well. Right, and then moving on to the next sign, it's called Crazy-Paving Sign. Everyone would have heard about this sign. That's nothing but it's how it looks like. I mean, you can see this. This is how the diagrammatic representation of the Crazy-Paving sign. Here what happens is there's a ground glass opacity with interlobular septal thickening that resembles like a masonry pattern what we see in walkways. So hence this was given that name Crazy-Paving sign, and it was originally described as a characteristic pattern of pulmonary alveolar proteinosis, you all know. And however, the sign has been seen in a number of other conditions like pneumocystis, carina pneumonia, or influenza or other viral infections. This is how it looks like. Classical example. You see multiple, there are a lot of patchy ground glass opacities with some interlobular septal thickening. Okay, and in this patient also has some cystic lucencis that that is associated with that disease process. Okay, here are some of the examples which will mimic these mimic this crazy, which will resemble or which has a pattern of crazy paving pattern. You can see influenza. It looks like that typical septal thickening in between those with the ground glass opacities. Multiple conditions, even the hemorrhage can give lipoid pneumonia, even the lung cancer for that can give rise to this appearance. So hence this is no more a specific disease pattern of alveolar proteinosis. So and then there's always history of immunosuppression in these patients, and the imaging findings of pulmonary cyst and spontaneous pneumothorax, especially this is with in patients of pneumocystis pneumonia. You can see all these findings apart from this crazy paving pattern to help in diagnosis of a particular condition. So moving on to the next is a miliary pattern. As you all know, it's consider multiple small less than 3 mm nodules of similar size that are randomly distributed throughout the lungs. This implies this is due to the hematogenous spread of infection. This pattern can be seen in the other organs as well, like liver, spleen, and kidneys. But you can easily identify this pattern using the radiographs. However, this is how it looks on a chest radiograph. This is very classical. Oftentimes it may be difficult to diagnose on a radiograph, chest radiograph. You can on the CT on the right side you can see the CT is multiple nodules, more or less uniform size, and spread throughout the lung. And this is also seen in multiple other granulomatous or other infections like histoplasmosis, coccidiomycosis, and this is particularly seen in immunocompromised individuals. You need to look for this. And these random pulmonary nodules must be differentiated from the centrilobular or perilymphatic distribution, which we have described as stream bud appearance. Here these nodules, remember the miliary nodules are distributed throughout the lungs and they extend to the periphery and come in contact with the pleural surface, whereas these stream bud or centrilobular nodule distribution usually will not touch the pleura. You can see the example here. You can see these nodules touching. Why these centrilobular nodules are stream but do not touch the pleural surface is, if you look at the anatomy of the secondary lobule, the terminal bronchioles end at the middle of the secondary lobule. With one of its surface is formed by the pleura. Hence, you will not see a nodule actually touching the pleura on a centrilobular stream bud appearance. Stream bud distribution of nodules, right? Hope I am clear. You can remember these nodules are distributed everywhere and they'll touch the pleura. The other sign, moving on to the next sign, it's called meniscus, Kimbo, or water lily signs of echinococcal infection. It's not a very, as you all know, the primary organ is the liver, that is the second most common is the lung that is affected. You do not have seen many of these many lung hydrated cysts. This is a diagrammatic illustration. You can see this light pink color is a pericyst and followed by the darker pink ectocyst, and the yellow one is endocyst. So there are signs associated with it. Meniscus sign is the one when a hydrated cyst is formed. Initially it is filled with fluid. Gradually, as it erodes into the bronchi, adjacent bronchi, the air starts to creep into this echinococcal cyst, and it will give rise to a sign called meniscus sign. You can see here that is a meniscus sign where the air is seen between the pericyst and the ectocyst. That's a meniscus sign, and then this is followed by, as the disease progresses, the air can dissect into the ectocyst area, which will give rise to this called Kimbo sign, or it is also called as onion peel sign, they call it. You can see this is the air crescent, and you have other nodules in the endocyst. in the endocyst region that gives rise to that appearance. And water lily sign happens when the endocyst, sorry, the yellow layer which collapses and then gives rise to the this kind of sign where all these locules, air locules fuse and form a single cyst. That's called, it's kind of floating lily sign we call it. So this is what it is about. So hence, to sum up, so imaging plays an important role in the diagnosis of any suspected pulmonary infection and may reveal useful signs at CT radiography. In, say, for example, these echinococcal infection signs are pretty specific, and even the split-pleura spine, split-pleura sign is again fairly specific of empyema. Halo sign, you can see this is seen in potentially serious and lethal fungal infections. So imaging signs of lung abscess with an air fluid level, it's characteristic of a lung abscess, and we can also predict and follow up and guide the therapy, guide and follow up for treating these lung infections. So I'll stop here. I'll deal about this imaging of community acquired pneumonias in the next session. I'm pausing here.